This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I'm 𝗧𝗃, physical therapist and your host, and today I'm joined by Dr. Seth Peterson for a conversation about how physical therapists can function in primary care roles in the US. We discuss how PTs are stepping into primary care roles in the US, what makes a primary care PT different from traditional outpatient PTs, how patients access primary care PTs, billing, collaboration, and how primary care PTs fit into care teams and more. Dr. Peterson is a board-certified orthopedic clinical specialist and a fellow of the American Academy of Orthopedic Manual Physical Therapists. He owns the Motive Physical Therapy Specialists in Tucson, Arizona, and is an associate editor for 𝗧𝗶𝗺 Cases and Orthopedic Physical Therapy Practice. Dr. Peterson has authored numerous publications and received awards, including the Emerging Leader Award from FAAOMPT and APTA. He is also a faculty member at A.T. Still University, co-owner of the movement Brainery, and hosts several podcasts. If you find our conversation informative, don't forget to subscribe, hit the notification bell for updates, give us a thumbs up, and share this episode with colleagues who could benefit from these insights. Thanks for tuning in, and let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like NeckCare.
Treating neck impairment? Get objective neck assessments with the NeckCare system. Learn more at neckcare.com.
Welcome to Urban Polling. Discover the Activator program and polls for rehab and balance.
Hi, Seth. Welcome to PT Pro Talk. How are you today?
I'm good. How are you, Mariana?
Good, doing good. I'm glad to have you here. So let's get started just talking a little bit about yourself and your background.
Yeah, so I'm a physical therapist in private practice. I'm in Tucson, Arizona. I've been there, about 12 years now. I moved down to Tucson. I graduated from A.T. Still University. So I did a residency in orthopedics, and then I went and did a fellowship in orthopedic manual physical therapy. I've been here. I'm loving it. We're building a building across the street, so the practice is doing well. I'm excited to see that finally done.
That's awesome. So you're growing your practice.
Yes. Yeah. It's been a fun process.
Very cool. Before we continue our conversation, I wanted to take a quick moment to tell you about a special offer from Sera Health. Visit serahealth.com/PTProTalk for a 90-day free trial. That's serahealth.com/PTProTalk. Make RTM simple. Choose Sera Health. That's serahealth.com/PTProTalk. And now let's get back to our conversation. So we know that our topic today is going to be how PTs can function in primary care roles, right, in the US. So how about we just get started defining what is primary care physical therapy?
Yeah, I think that's a timely question. So for those of you that don't know, APTA Federal has a primary care special interest group that was really tasked with defining what primary care physical therapy is. And I think I don't envy that task. It was probably difficult to pin down exactly what this is. It's kind of like at least to some of us, it's kind of a nebulous area of practice. It's unique. And you can see, I can just read the definition that they have on their website and then talk about it. But the definition that they settled on is primary care physical therapy is defined as physical therapists providing comprehensive wellness, triage, diagnostic, and management services within primary care pathways for individuals with physical and functional needs. The primary care pathway can be defined as the organized and integrative plan of care and service delivery for an individual who seeks primary, first line, in other words, healthcare services for preventative care or to address physical, social, emotional, cognitive, or functional needs. So it's kind of a lot to chew on, but if you kind of boil it down to what did they say primary care physical therapy is, it's this comprehensive approach to care, really, and then situated within this primary care pathway. which again, they said was like an organized and integrated plan of care and service delivery for first line presentation. So, I think the easiest example historically for this has been PTs within the military, which is why primary care, the special interest group, has been with APTA Federal, has kind of been leading the charge on this, because it's just this obvious scenario where they've been practicing within that integrated environment as first line providers for a long time. Once you get into the kind of the area that I practice in, it's a little interesting, and you get, depending on the people I talk to, you get a little bit of pushback. Are you really in primary care? Then what is it? So it's interesting.
And before I forget, we were discussing that prior to starting the podcast, that you were talking about how it could potentially become a new specialty area, right? So do you want to just mention that, what's coming up in the next few months?
Yeah, so even the reason that they came up with this definition was part of developing this as a forthcoming specialty area. So they went through the process of essentially getting this approved. The next step is to get it rubber stamped by the House of Delegates, which represent the members of the American Physical Therapy Association. And the House of Delegates meets in the middle of July. So you can look forward to an update there. I haven't heard of anything getting rejected at the House of Delegates level. So it goes through a ton of review prior to that. But it's kind of interesting, because this is different. When you talk about specialty areas, it's really going deep. And they talk about this in their paper, which you can find on APTA's website, Defining Primary Care PT. It's different in that a lot of the specialty areas that we have now, if you think of orthopedics or neuro or pediatrics, it's going really deep in an area. And what primary care PT is this concept that they coin in the paper, 3 miles wide and 3 feet deep. So you have this broad perspective of the individual across multiple body systems and, currently specialty areas. And then maybe your knowledge and expertise in each individual area might not be that deep, but you have this broader perspective that you're looking at the individual with. And that they're not mutually exclusive, right? So you can have this broad perspective, and then, I'm a specialist in orthopedics, so I can go deeper in the orthopedic realm, maybe not so much when it comes to pediatrics or, the neuro system, right? And so I think that's maybe what's different about primary care. And so when we met as a delegation to kind of talk about this evolving specialty area, it was interesting to hear that particularly like PTAs don't really understand what's the difference between this and entry-level practice. They see this as, well, can't you do this when you graduate from PT school? You should understand a little bit about all these specialty areas. So why is it that this is a specialty? And I think to answer that question, it's different than the other existing specialties that we have. But when you look at, sometimes it's helpful to look outside of the profession. When you look at like primary care within, primary care physicians, what they do, they're at a higher level than people that just graduate from medical school, right? Mm-hmm. They've gone through this residency to deepen their knowledge and their expertise within practicing as a primary care physician. And I think it's the same for PT. You can practice at a high level. It's this higher level of practice, understanding how to do it more efficiently, being better at your differential diagnosis. So your skill set is more refined, I guess, than what it might be when you graduate.
Yeah, and since you're talking about that, I check the MedBridge course that you have there, and I was just looking at the outline. So it seems like you're just, learning basic tests, how to screen for other serious conditions, differential diagnosis, and things that you need on the day-to-day practice that as PTs, and we know after you graduate, you go to your area and then you are not in touch, seeing patients in the different areas. So it makes total sense that you have to, pass through different areas and learn the basic screenings, right? To be able to screen those patients properly and be able to refer them or diagnose them or, whatever you need to do.
Yeah. I think there's a couple ways we can go about it. We kind of framed that course on MedBridge that you talked about. So it was me and John Hike that did that course. And we talked about it as a philosophy of care, primary care. So it's this philosophy of how you approach someone, looking at them holistically, kind of this first person model. But we touch on these areas that maybe we think that we understand well when we graduate, but really you can see that the evidence is really that PTs largely don't. So like the systems, understanding the system within which you work isn't really that great. I know when I graduated as a PT, it's so crazy to look back on this, but I thought that if you got a referral from a physician, that person had already been appropriately examined and the more serious conditions had already been ruled out. So once you got that referral from the physician, you didn't even have to really do anything. And that's totally different from reality. You have to understand what is this, this concept of system-based practice that we go into in the course that people don't really understand very well. And it grows and deepens with your experience within that system. So I understood, existing within that system, that doctors really don't have that much time to do that thorough of an examination with their patients. A lot of times they're sending patients to physical therapy so that we can do that examination. And then also understanding just, going a little bit deeper into how conditions evolve over time, which we sometimes don't think about. So, I distinctly remember presenting a case at, I think it was a state conference, and talking about a colleague who saw someone who presented with neck pain and pain kind of in the scapular area. They had pain when they moved their neck in that region. So they assumed this was after examining them, assumed it was a normal musculoskeletal problem. That's common for the neck to refer in between the shoulder blades. And so they went ahead and treated the neck, and they had some kind of initial success. After, maybe the third, fourth visit, they kind of had gotten worse. Sometimes that happens in treatment. Then the patient fell off the schedule after the third or fourth visit. Okay, this colleague of mine was also doing a few days in the hospital. So they actually saw the person's name in the hospital as they were walking past a room, and they come to find out the person had a tumor.
Oh, wow.
Right. And I just remember someone in the audience saying, well, this person should have picked it up. And it's like, well, no, things evolve over time. So that person might have initially just had a stiff neck. And, there's only so much maybe they didn't have unexplained weight loss or a history of cancer. They were in their 30s, if I remember right. So they didn't initially have those symptoms. And then as time progresses, they start to develop symptoms. I know by the time someone has a bunch of red flags, in the case of malignancy, it's probably pretty advanced. So we should, we have to be forgiving with our colleagues, but also things evolve with time. That's important to understand. And then where you are within the system. So I think primary care, that's one of those things that I think where you transition from maybe entry-level practice into more of an expert level.
Yeah. And so what is the scope of a primary care physical therapist?
Yeah, so that's essentially kind of what I was just alluding to. If you look at that definition paper, they also go over what their kind of defined scope is in the primary care PT. So their kind of competence and knowledge, which is what they're saying with that 3 miles wide thing, is they have knowledge across multiple specialty areas, across the lifespan of this individual. It's interesting when you talk about scope in the context of like, what can you do for ordering imaging, ordering testing, et cetera, because in the private sector, which is where the majority of PTs practice, it varies from state to state in terms of what we can do. So, so that's maybe kind of pivots to these interesting discussions you can have as far as, how much should we go into, education about imaging? How much should we talk about referral? But I think if you just look at it from a general perspective, that's what primary care PTs do. They're just this, maybe having more expert level knowledge in triage and managing these conditions that work across multiple body systems and with, other individuals in the healthcare team.
Mm-hmm. And that's a big difference from primary care PTs from the outpatient physical therapists, right? So they have that deeper knowledge across different body systems. They work with like a provider team, like other healthcare providers, right? So like, what else would you say that makes them different from the outpatient PT?
Yeah, I think it depends on exactly the setting in terms of how much leeway that they have, where in the United States, if that's what we're talking about, where they are. If you look outside of the United States, I mean, it's just, totally different in terms of different countries have, advanced scope of practice for certain physiotherapists. But within the US, it's really, I would say that what the primary care PT can do is do this kind of, be adept at this kind of triaging process, understanding what is the appropriate action to take at the appropriate time with a patient. There are different things that I think maybe don't get enough attention at entry level that you can really go deep on in something like primary care PT. So how do you, if you have a patient that looks like, maybe they have like one red flag, they have, maybe they're a little older, you think, maybe there's something that might be there, but you're looking at it like, so the 𝗬𝗧𝗶𝗺, maybe I'll introduce this. If you aren't aware, has a paper on the red flags for potentially serious spinal pathology. And I like that it's a framework that was developed by 𝗬𝗃OMPT, the International Federation for Orthopedic Manual Physical Therapists, and this kind of task force there. So they developed this framework to kind of look at a person when they walk into your clinic. And one of the things that was really evident in that framework that's important is the urgency of the problem and the consequence of delay of that problem. So imagine if you have a person and you think that with all of that they might have, like we just talked about, a malignancy. But they've kind of had these problems that have been bubbling up for a year and a half. Okay, so in that scenario, the consequence of delay probably and urgency are probably a little bit lower. I mean, the consequence of delay, if it's a serious malignancy, might be a little bit higher, but essentially you can wait. It's been bubbling up for a year and a half. It's not like tomorrow they need to see someone. As opposed to, someone walks into your clinic and they say, hey, they just got dizzy suddenly. They were on the treadmill, they turned their head, their vision changed. Then their neck is all stiff and they have a headache. And maybe you think that, you do a cranial nerve exam and you think maybe they are having a cervical vascular accident where they need to go to the emergency room. That thing comes on quickly. Urgency is quick. Consequence of delay is high. And then how you act in those different situations is different. And that's something that when, to go back to what we talked about earlier in entry-level practice, that would have just frozen me in my first few years in practice. And I think there's a lot of, within PT, there is a lot of that. It's, you don't run into these cases as often. And so with primary care PTs, there's an element of, you talk about these scenarios and how to act, and then experience in terms of how to respond to these scenarios when you're presented with them. so that you can make the best decision for the patient.
Yeah, because we learn about all these possible case scenarios, but it's not our day-to-day practice in the outpatient setting. So I imagine that's probably very scary when you start seeing real-life cases and then you have to perform those tests that you never have to do it. So then you have to know them. So how do you develop that skill set as PTs? Because we know we have that basic level of knowledge. We end up not really using much of like specific like tests because it's not our day-to-day reality. So what do you recommend PTs that are interested in that? Like what they should do to start developing that skill set?
Yeah, I mean, always the best scenario is to have some sort of mentorship. So I'm looking forward to seeing kind of residencies develop in this area. But also, you can look for opportunities to learn about this. So if you're in, maybe there's someone in your clinic that does a very good job at this, you can talk to them and try and have them give you some tips about, and that's going to help with kind of the systems-based practice element. How maybe there's this PT that's been in that system for 10 years. If you're in, housed within a hospital, how do they practice within that system? Or home health. I remember I had to talk to someone that had been in home health for their whole career and could give that element of insight. Well, how do you communicate best with these individuals within this specific system and work within that system? But then in filling in the gaps in knowledge, I think there are some great courses out there. You talked about the MedBridge course. We also have a course on with the Movement Brainery, which is our continuing education company. That's another asynchronous course. And that just helps, I think, with filling in kind of differential diagnosis. But we also try to talk about action and how do you, like we talked about, make the best decision with your patient at the right time. What I also alluded to, because we've talked about kind of these more urgent or serious pathology situations, but it's also primary care would be, like we talked about earlier, this holistic or person-centered approach, or even preventative care. So there are other elements that kind of feed into that. So you can take, maybe if you don't know as much about dietetics or nutrition, you can take some courses on that and branch outside of maybe just PT courses even. What might you take there? We talk in our both of our courses actually about the endocrine system, which I think is maybe underappreciated because it affects every cell in your body. And so understanding when someone comes in and they have an endocrine condition, like a thyroid condition, what does that mean for them? If someone has an autoimmune condition, what does that mean? Especially if it's a systemic autoimmune condition, how is that going to affect even your ability to do exercise, or how should it affect your exercise prescription? Thinking about all these different factors. So you have to learn about all these different things just a little bit. So maybe, if you're an orthopedic PT trying to get better about primary care, then maybe taking, when you go to your state conference, instead of taking the ortho track 1 year, maybe you go in the other track with the neuro folks, or you take a different sort of course just to learn a little bit about that.
Yeah, that's a good idea. It is just, it's hard when you're not practicing on your own on the area. So I assume they're going to start popping up more courses eventually to help people with that, right? I assume.
Yeah, I expect more courses to come out, and I expect more models to come out. I mean, kind of this direct access to PT now is growing. I know all states have some level of it, although there's a huge difference between different states in terms of what that looks like. But direct access makes a huge difference. Direct to employer care models are growing, so that's another one that is kind of a primary care pathway. We talked about that in Katie and I's paper, direct to employer models. And so there are different models that I think will kind of expand as time goes on too.
Yeah. And so what are the typical settings that primary care PTs can practice?
Yeah. So I think that's a good question. We talked about it in our course. I think the philosophy of care of being a primary care physical therapist is important. Where you are is important as well. That's another component of it. So direct access care, you're in an outpatient clinic, and if you get people coming to you when they have concerns that they think might be musculoskeletal concerns, someone has this acute onset of dizziness and they call up your clinic, you're in a primary care role at that point. But there are, as far as other models, we talked about, federal systems, how you're going to work within the federal system, the military health system, VA. Those are examples of, where you're practicing, where primary care exists. There are different places that have used these free clinics. There are regional health systems that, physical therapists can be positioned in more of a primary care role. The emergency department, in many cases, that's like a primary care role. You're doing a lot of triage in the emergency department. Those are common. International PTs and international physios, I guess I should say, also have kind of interesting and unique models in terms of where they are. Like the UK, I know, has these first contact practitioners, which have additional training. So it's different. I think it's growing. But I think also I'd encourage you, if you're listening to the podcast, to kind of look in your local area, and you could contribute to this. If you felt like maybe you had the skills, the knowledge to practice in this role, what could you do to create a role that might help benefit patients that might be more of a primary care role?
Mm-hmm. And how about like primary care clinics? Like, do you see physios there with other healthcare providers?
Yeah, there are a couple PTs I know in the US who kind of practice out of a primary care clinic. And I think that's great, because we have this musculoskeletal knowledge that really, if primary care doctors, and this has been amazing to me every single time when I interact with them, if they see the knowledge that you have in the musculoskeletal system, immediately they're like, oh, well, you should be seeing all these patients.
Please help me.
So if you can find a doc, I mean, there are a lot of scenarios. Like, we rent the place that I'm in right now from a dentist. But if let's say you have a primary care doc that has rooms that he doesn't use very often in his office, he's paying rent on them. Can you sublease out a room, a couple days a week? And I've approached primary care docs about that, and they just haven't had enough space. But I think that would be interesting, how you could develop sort of a pipeline there where you could see patients a little bit faster with musculoskeletal complaints. I think would be huge if you can do that. So look for opportunities to do that. Yeah.
And like, do you see, for example, in that case that you just mentioned, being like one visit, like you screen the patient and then you refer to the appropriate provider, or exams or labs or whatever it is, or like, would you be seeing that patient in a more long-term situation? Like, how would that work?
Yeah, I mean, I think that depends on how exactly you want to develop or design the thing that you're going to develop. So you could, emergency department PTs, that's what they do. I mean, they basically just triage. They don't have time to see someone through a whole plan of care. So it's okay. You have acute low back pain, so you should be going to outpatient PT. If they do a really good job, they might say, this is the specific outpatient PT in our community that I want you to see. Here's, a referral to that individual. I'm going to reach out to them to connect you guys. But then you could, at the end of the day, I think when we, and we talked about, maybe this is a good point to talk about referral. So we did write a paper. This was the first paper that we could find in PT on referral decision making and continuity of care. So if you're, basically what we've talked about historically in PT when it comes to referral is not much. It's like the role of the PT is, are you going to treat? Are you going to refer? Or are you going to treat and refer? And that's pretty much where it ends. You make that decision and then there it is. But referral decision making can be a lot more complicated than that. And we need to think about that. And it really comes from this idea that you're going to do what's in the best interest of the patient. So that was published in PTJ maybe last year or the year before, but we talk about a lot of different things that are in the physician literature where a lot of this is housed in referral decision making. But you have to talk to the patient and kind of solicit what are their values, what do they want, what do they want to do. So maybe in that scenario, if we're thinking about how to provide a good, high quality referral, if you're in the emergency department and you're talking to a patient and they say, man, I've had a horrible experience with PT before. I don't want to go back. Mm-hmm. Or it's too much money. I can't afford PT. I've been there. My insurance doesn't cover it at all. I just don't have the resources to do it. Then you kind of can decide in thinking about, okay, is this person going to be open to a referral to a different PT who might be give them more value, or should I just show them a few things? So that factors into your decision in terms of what the patient values are. And there are other things, what type that we talk about in the paper, what type of referral are you making? So there's a difference between referring out with, a referral for someone, like let's say you're referring to a primary care doc to get, not a primary care, let's say you're referring to like a rheumatologist. So it's a consultation. You want their input on a patient. Like, is this a rheumatological condition that I'm seeing? Mm-hmm. So that's a different type of referral than referring to a neurologist so that they can do a nerve conduction velocity test on, to try and see, does this person have a lumbar radiculopathy, or is this like a peroneal nerve injury? That's more you're referring to them with kind of the explicit intent that you want them to do a test, or you're at least, maybe it's best when you're communicating with physicians to say you're recommending a test. Mm-hmm. Right. So different. In one of them, you're looking for their knowledge, their input, and another one, you're kind of just wanting them to do the test so you can move on.
Mm-hmm. Mm-hmm. Yeah. And on those models, I remember seeing I think it was the Canva that you sent me with the definition and things. There was like a calendar that you could like just do rounds in a primary care clinic, right? So you would have, for example, depending on the need of the clinic, so you just go and stay there like 2 hours in the morning, 2 hours in the afternoon, or something like that. Instead of you being there like full time involved in treatment, you are just more kind of like screening, I guess, right? So that could be one scenario when working in a primary care clinic, depending on their demand and depending on the time you have also, to instead of treating the patients, I guess.
Yeah. Yeah. So, I mean, they're basically like you're talking about, you're in a triage role where you're figuring out, is this someone that needs to, go stay here and has a serious condition, or they just have acute low back pain and they can go to a clinic that treats low back pain. So that could be a role. You're kind of evaluating what appears to be a musculoskeletal problem. And that's a lot of what happens in the emergency department. But there, like we've talked about, there are a whole bunch of other settings that primary care PTs can operate in. So,
mm-hmm. Yeah. And when you are working in a primary care clinic that you can, or maybe an emergency department that you can integrate with other healthcare providers, right? So we know that makes everything a lot easier. And also you have a lot of good results, right? Saving resources and better outcomes, and patients are more happier, right, with the results. So what are the kind of results that you've been seeing on those type of setups?
Yeah, I think that's a good question. So it's not just, hey, we're trying to, get to the front of the care model so we can see more patients. It's really, I think what's driving this is the research evidence that it leads to better outcomes for patients. So yeah, I mean, we have a table in that paper 𝗧𝗶𝗺 was the lead author on, where it kind of summarizes a lot of the evidence about this. So there's multiple studies that this saves the healthcare system money. It reduces wait times for patients. So we talked about kind of that in that primary care setting, one way that you could do it would be like the warm handoff, where the nurse practitioner or physician kind of screens the person. Hey, this looks like a musculoskeletal thing, and then immediately the person is seeing a PT. And so it makes sure that immediately they're getting in there. There's increased utilization of PT. They've shown in papers. Patients are more satisfied. Providers are more satisfied. Almost universally, papers show primary care docs love this concept. So there's, when we did this, I don't know what to call it. It was like a webinar for the MedBridge course. We had a lot of people attend, and a lot of people asked, what's the reaction that doctors been? As if doctors don't like PTs kind of infringing on this. And largely, providers love this. It helps them. They're overloaded, so it helps them. So again, it helps people get back to work a little bit faster, reduces unnecessary imaging, and I think maybe reason that primary care docs like this is it reduces their workload. There's evidence that occurs as well.
And especially because they don't have that specific knowledge, right? So like we saw, if it's a MSK condition, they would probably be very happy to hand that to someone that can take care of it and knows what to do and have more knowledge on the topic, versus them being overloaded with all these patients. So let them free to do what they are good at, and refer that to a special PT that can treat the MSK disorder much better.
Yeah, absolutely.
Yeah. Okay. And so you feel like in the healthcare team that's well received, mainly for other like primary care providers. So you said the physicians. Do you think the nurse practitioners, the other healthcare providers on the team also see that as a positive thing in most cases?
I think so. Yeah, I think so.
Yeah.
I think maybe my own experience is just primarily with specialists that I guess you should be part of practicing in primary care in a systems-based, having knowledge of, systems-based practice approach, where you have knowledge of the system in which you practice, is understanding how to communicate with docs. And maybe if you have within your community certain docs that are maybe a little more sensitive to certain things, you just learn how to communicate with them. That's part of developing expertise in this area, I think. And so, neurosurgeons, I'm probably not going to question what they do outright or to the patient, but we might. Maybe I can summarize some evidence to that if there was something that maybe I think they missed, depending on the individual person. But how you approach it is a little bit different depending on the person. Maybe if you have like conflicting diagnoses. But largely, this has been positive. And people asked as well, when you refer out to a doctor with a specific test in mind, like we talked about that nerve conduction velocity test, have you had any negative reactions from docs? And no, we have not. We've been doing this for a couple of years now, and we have not had a single negative response from doctors. I think largely they like it. The feedback that I got, or that I'd heard for basically my entire career, is what doctors don't like is getting a referral that just, they send a patient to you and you're sending them back, and they don't know why. So it puts them in a situation where like, well, all I know is that look like low back pain and I sent them to you. And now they're back in my office again. So they don't like that, which is understandable. So when you refer them back, there has to be information that they get. So we talk about in that referral paper using an acronym where you kind of just summarize the information for them. So the 𝗧𝗶𝗺 format is the acronym. So SBAR, and it stands for situation, background, I think assessment, and then kind of the rationale. So you're giving a little summary to them and then why they're coming back, basically. And you're making it short and sweet for them.
Mm-hmm. Okay. And how about PTs that work in like a standalone setting, acting as a primary care, basically? They don't have that easy access as they would have if they were working like a primary care setting or an emergency department. So then in that case, what do you recommend? It would probably be easier for them to have a lot of like connections that they can refer, like doctors, people that they know they can work with to make things easier. In that case, how do you see that happening?
Yeah, I mean, that's basically the setting that I'm in. I mean, I'm in an outpatient private practice. We specifically talk to patients about how, we can see you direct access for conditions. You can call our office. We can get you in. If it's an emergency problem, we can get you in faster. We see people with dizziness, so BPPV, usually most often is what that is. And we can see them like in the same day if they develop dizziness. We can have these short little appointments. We have implemented this like digital PT triage thing, which, the adoption of that has been a little bit slow with the patient population in this area because they're a little bit older, but it's still available to them. And it's like basically doing a virtual consultation to figure out, should they come to PT or should they go, to the emergency department. So it's doing some triage there. So you can set up these little avenues if you have the ability to do that. If you're not the owner of a practice, you can talk to the owner and try and figure out, is there a way that we could, provide this for our community? But then when you're in an area, I think it really is important to understand, again, just coming back to this systems-based practice approach where you understand the environment that you're in, and that includes the settings that are around you. So like understanding where this person lives, which hospitals might be near them, which hospitals for this problem maybe aren't the best. You can understand that after a while. So you can begin to see that there are certain hospitals, if you do have to go to the emergency department, it's worth driving an extra 10 minutes in this direction versus that direction, because you'll see better doctors for that condition that work out of this hospital. Understanding those little nuances, maybe having good relationships with different doctors, being able to get people in, like an urgent referrals. This really helps for cardiovascular problems. I've found where, being able to get through to a cardiologist if, say, like blood pressure is really high, so that they can, talk with the patient and see them maybe urgently in an outpatient setting, saves them a lot of time and money for the patient versus having them go to the emergency department. And they don't really do that much for the ED for blood pressure management. So, but understanding those little things and what you can do and how you can contribute. And if it is something like an urgent referral, what are the best mechanisms for that within your community?
Yeah. And how are typically primary care PT services reimbursed?
I think that's important. That's a good question. there are different things like with ultrasound, where I know that there's musculoskeletal ultrasound, where there's different considerations in terms of payment for that. But by and large, if you think about what we're doing, where we're providing an evaluation, I think that is important to acknowledge that if you're doing a lot of evaluations, at least for Medicare, that gets paid at a higher level. So you're doing things and maybe helping the clinic. This is maybe how you could sell it to the owner. If you're doing more evaluations, you're bringing more money into the clinic. But we don't, as a primary care role that's not necessarily intervention focused, you're still as a PT doing the same interventions. So from an intervention standpoint, you're still getting paid, the same amount.
Mm-hmm. Yeah. And like, for example, if you are in a primary care clinic that you're doing like rounds and just, getting referrals from physicians and that kind of thing, do you know how would that work in terms of reimbursement? You would be like billing just assessments, because that's like kind of a different service, even if you're like giving your opinion. So like, how would that be structured?
Yeah, I mean, I think it's interesting. I guess I can't speak too much in terms of if you're housed within a primary care practice and you're underneath maybe the NPI of the physician. Can that be billed differently? I'm not sure. I would think you would still bill the same codes as a PT, but I could be wrong. I can't speak from experience on that.
Mm-hmm. Yeah. And also there are different models like that people start charging more, like memberships, right? Self-pay and other things that could be structured differently too in those type of settings potentially.
Yeah, I mean, we talked about direct to employer, which is a big area now, and I think the reason is, you can, it's different. I mean, you can have different models for direct to employer, but you're contracting, like it sounds like, with an employer, and so they're different. There are tons of courses that you can go to, and direct to employer, the APTA is putting out resources, I think, at a decent clip as far as that goes. But the private practice section is as well. And there are a whole bunch of different models as far as that goes.
Okay. And I just wanted to briefly talk about the referral for imaging in Arizona that you said that was something that we could potentially discuss. So do you want to talk a little bit about that?
Yeah, I mean, I think that it's just important, I guess, for everyone to pay attention to what's happening in your area. So, here's my pitch to, be an APTA member, especially within your state. Try and be active so you can be aware of what's happening from a legislation standpoint across the country. There's really been changes in Arizona. I think we've experienced that, where maybe when did this start? I mean, if you go back to just even COVID, right? So we couldn't do telehealth, and during COVID, we've all kind of experienced that, where all of a sudden telehealth was a big thing, and then you could do it, and then you had to understand how do you do a telehealth consultation with someone, and that was a different thing, and Medicare was paying for. And then now across the country, one of the changes is there's been a wave, I think, that started with Wisconsin explicitly moving the needle to approve radiographic referral privileges for PTs within that state. Okay, in Arizona, we did a similar thing a couple years ago, and then I think it was last year it got moved to include all diagnostic imaging, so we can refer for MRIs, CT scans, whatever we think is appropriate. And again, in the systems based practice approach, understanding your community. That's the big takeaway, I think, from this podcast. Right down the street from me is an imaging center. So a couple years ago, we've walked down there. We talked to the people at the front desk. We have referral forms, so we can literally say, "Hey, I think you look like you might have a fracture. For detecting this fracture, the best thing to do is to get an MRI. Let's say this is a stress fracture or something like that you're suspecting. Okay, I'm going to refer you down here, right down the street to the imaging center. It's 2 doors down. So I want you to drive over there. We'll send a little form with you. So you can communicate with that center to what do you need? How do we get people in? What's the expected wait time? Is there kind of a way that we can get people in urgently? So you understand that. So that's been a learning process. But as that, I guess, to circle back around, encouraging people to be aware of that so that when you do get those privileges, which are expanding across the country, not just in Arizona, more and more states are doing this to give PTs explicit imaging privileges, then I think it's a good idea to go and understand how you do that efficiently for the patient, talk to those clinics and in your community.
And in that case, would the exams be covered by the insurance? Or you're able to refer, but then the patient would have to pay out of pocket?
Yeah, for the actual images themselves, I think that's another important consideration. So right now, Medicare, CMS, doesn't include physical therapists as people that are authorized imaging, people that can refer for imaging. So if it's a patient that's on Medicare, it might be a good idea, and maybe I'll talk about, kind of how you make these decisions for referral. So let's say you think it's a good idea for someone to get an MRI, and then you look and you see, they're Medicare MRIs out of pocket, maybe are cheaper than what's billed to insurance, but okay, who's your primary care doctor? Is it? And then you can think to yourself, is this someone that's likely to respond and get this person in quickly? What's the urgency of this scenario? So there have been patients where I think they need an MRI, and we just call their primary care doc, and we also fax over a form saying, hey, we think this person would benefit from an MRI of X. This is what we want you to, what we recommend you ordering. What do you think? And there have been situations where it's a Medicare patient, and I know that there's a different imaging center that offers pretty reasonable cash rates. So for them to go get an MRI, it might be $150 cash. So I just say, hey, rather than waiting in this scenario, because I know you're a primary care doctor or you don't have one, would you be willing to spend $150 and just go to this imaging center? And some of my patients say, yeah, let's just get it done.
Mm-hmm. Yeah. Gotta assess the situation, see what's gonna work best for that specific patient and insurance. Seth, before we wrap up, anything else that you wanna add about physical therapists functioning primary care roles? Anything we forgot that you wanted to mention?
No, I think this is just something that's just so. I think this gets me excited. I think at the end of the day, just because it's in the best interest of these patients. At the end of the day, that's what we're here to serve. And I think if you look at the evolution of PTs through history, where we started as reconstruction aides to now we're diagnosticians. Now we can, order imaging. And this year we have primary care physical therapy getting, hopefully approved as a new specialty area. I think it's something to look back on and say, man, we really have evolved as a profession. And I guess just urging the PTs that are listening to this, if, I encourage you and your communities to evolve and learn about this stuff a little bit. And it's exciting. I mean, sometimes you get bored going to the same, orthopedic courses for the, millionth time. So branching out a little bit and taking a different, a course on a different thing can help improve your ability to care for those same patients. So that's kind of what's excited me, and just finding new things to get excited about to improve your, ability to practice as a PT is huge.
Yes. And any resource of information that you would recommend people to go to look for more information in this area?
Yeah, the things I think that I've referenced a few so far, but just to go back to it, there's a paper 𝗧𝗶𝗺𝗏 and I wrote called Physical Therapists in Primary Care in the United States, an overview of current practice models and implementation strategies. That was in PTJ. The paper by John 𝗧𝗶𝗺 was also in PTJ, and that was in referral decision-making and care continuity in physical therapist practice. Then if you want to go to find out more about primary care, the definition, you can just go to APTA's website and search APTA in primary care. If you want to find out more about that direct to employer stuff, they also have a web page for that. So APTA direct to employer, you can search for that stuff. And so those will bring you to most of the resources that we talked about.
Okay, that's great. And then if people want to learn more about you, you also have a continuing education company, right? So where they can find you?
Yeah, so we have the Movement Brainery is my continuing education company. We have a primary care PT course that's available there. Like I said, John 𝗧𝗶𝗺 also did a MedBridge course that's out now, so you can sign up for that as well if you have access to MedBridge. So yeah, those are two resources as far as that goes. You can find me on Twitter. I'm at Dr. Seth PT, and then the Movement Brainery does have an Instagram account too.
Awesome. Seth, thank you so much for taking the time and talk to us about this topic that now it's, becoming hot, and we're going to have in a few months, hopefully become a specialty. So I'm super happy that you came and just chat with us a little bit about that. Thank you so much for your time.
Yeah, thanks, Mariana. Thanks for having me.
That's all for today's episode of PT Pro Talk. We hope you enjoyed this discussion. Be sure to follow us wherever you listen to podcasts so you'll be notified when we release future episodes. You can also join our email list at ptprotalk.com to receive updates and access new episodes. If you have ever gotten value from the show, please take a moment to leave us a 5-star review. It always makes my day, and it really, really helps us out. If you have any guests or topics you'd like to see on the show, let us know by answering a quick survey. You can find the link in the show notes, along with more information about our guests, resources, website, and social media. Thanks again for listening, and until next time.